Well, in my second talk, I do actually get to talk about something I'm also very passionate about, improving outcomes after total joint arthroplasty and while reducing their length of stay in the hospital. The focus of this presentation is the how and why. We believe that getting patients home sooner is not only better for them, decrease incidence of complications and improved outcomes, but better for us and the hospital. That is through improved patient satisfaction and cost effectiveness. It is not just an end in and of itself. When I first started doing knee and hip replacements 20 plus years ago, in 1985, our length of stay was 11.5 days. Last year, it was 1.18 days. So we're getting our patients home sooner and in better shape. The vast majority of our primary and even revision total joint arthroplasties are discharged home post-op day 1. That's not going to a skilled nursing facility. That's not going to an extended rehab. That's going home. We started to look at data from last year to see how we were doing, and what we had available to us was the federally mandated coded data that the hospitals in my home state of Georgia in the United States submits to the government for collection. Of those 594 patients, our length of stay in this group included revisions was 1.4 days. The return to the emergency room within the first 2 weeks was 0, and the readmission rate within the first 30 days was less than 1%. So how do we get there? This started about 8-10 years ago. We slowly improved, trying to understand what we need to do to get patients better, to get them better quicker, and also get them back to their work, activity, sport. Now, is there a single factor which impacts outcomes? Well, there was an article by Jones that stated that there was mounting evidence that suggests that there is no single factor, patient-related or perioperative factor, that clearly predicts the amount of pain relief or functional improvement after total joint arthroplasty. Now, is there a perfect candidate for a joint arthroplasty? You know, is an athlete or a healthier, younger person better to recover? Young, in this article in 1998, said, and what they found was the best functional outcomes and prosthetic survival rates were reported among patients who were between the ages of 45 and 75, weighed less than 70 kilos, had strong social support, had a higher educational level, had better preoperative functional status, and no comorbid disease. Now, if I only could find one of those, that would be pretty good. Now, should we look at surgeon-directed factors that influence total joint arthroplasty? Now, there's a lot of discussion even outside in the exhibitors. There's different type of implants. Fixed bearing versus rotating platform for total knee arthroplasty. There's modular femoral stems for total hips. There's differences of surgical technique. We've all heard and know about the minimally invasive surgical techniques in total knee arthroplasty. There's the new anterior approach to the total hips. There's navigation. There's custom cutting blocks. And there's perioperative protocols. None of these have been shown to prove short and long-term benefit other than perioperative protocols. And we actually presented one back in 2006 at our Academy of Orthopedic Surgery meetings. Now, we should look at patient-related factors and how they influence total joint arthroplasty. Now these are more interesting, I think. Patient expectations, nutritional status, preoperative functional status, psychosocial status, and preoperative pain level. Expectations of patients for quicker recovery and improved outcomes have by themselves been shown to improve the patient's perceived outcomes. Muhammad wrote this in 2003, excuse me. Now that's basically saying if people believe they're going to do better, they often perceive themselves doing better. Better nutrition. There's been several articles talking about hip fracture recovery and total joint arthroplasty that shows that better nutrition leads to improved outcomes. Preoperative function was a significant predictor of longer-term outcome after total knee arthroplasty in this Kennedy article. So the better we get them into shape prior to surgery, the more likely they are to do better after surgery. Also, emotional health. Ayers talked about poor emotional health leads to small improvements after total knee arthroplasty. Those folks who are not doing very well prior to surgery may not see as much of improvement after total joint arthroplasty as they otherwise could. These psychosocial variables are significantly related to total knee replacement functional outcome, especially motivation, also role functioning, both in emotional and social function. So we're talking about all the things that are not implant related. We're talking about all the patient factors now. These are very important to assess and deal with to get our patients better after total joint arthroplasty. Preoperative depression and anxiety were also associated with heightened pain 1 year after surgery. These are factors that we can intervene with prior to surgery and perioperatively to help our patients get better. Vicki Brander up in Chicago with David Stolberg found that patients with greater preoperative pain had more postoperative pain. So we needed to design a comprehensive protocol. We designed one to help facilitate quicker recovery, shorter length of stay, by limiting known complications perioperatively. We also focus on improving patient medical and psychological management, and we improved communication with the patient. It was designed simply so that it could be implemented in any hospital. It included extensive education preoperatively for the patient. It was relied heavily on consistency throughout their contact with the system, both in my office and in the hospital. And we had a thorough discussion of expectations. Pain control, which is extremely important. We believe in stacked modalities, as I'll explain a little bit later. Blood management is important, as is early mobilization. And we also feel that implementing a nutrition program does help. Anesthesia. We tend to use general anesthesia now because our cases are so short. But at one point, we had 99+% spinal anesthesia. But if it's cases under an hour, it really doesn't matter which way you go. Nausea control, I think, is absolutely important and one that sometimes gets overlooked. The patient gets nauseated, they lose a lot of time in recovery, so we try to control this preemptively with medications. They get discharged home the following day. If they're cleared by physical therapy and are medically stable, they have to walk 100 feet, do stairs, get themselves out of bed, and then they can go home. Through this, we've been able to reduce our length of stay significantly, but more importantly, our patients are doing better. Their time to return to work, their time to driving, their time to return to activities, and time to return to sports have shortened. The use of ambulatory assistive devices has been lessened, and the patients are more satisfied. So how is this done, you might ask? Let's get into some details. The complete recovery program really starts in the office. It starts with the preparation for the surgery. Lots of education and understanding what are the risks involved with that individual patient that may lead to complications. Then there's hospital care, both in the holding area prior to surgery, surgery itself, the recovery room, the hospital floor, nursing, and then discharge planning. And then the recovery period. I break this down to 3 groups. The first 4 weeks, I actually believe, is truly the recovery period. It's just the fact of getting over surgery. 4 to 16 weeks, the first 4 months, is more beginning of the rehabilitation process. And then for the rest of the year, it's getting back to normal. Skip through this pretty quickly. Preparation for surgery. It's probably a little bit different down here as well. But we look get them into the best medical shape that they can be in. We get medical clearances. We get the appropriate labs and EKGs and such. But I think the most important is the education. The patient education assists the patient in having clear expectations of the recovery process and the knowledge to implement a home regimen to achieve the desired outcomes. We make telephone calls to the home. We get them prepped from their physical therapy point of view. We involve their family members. Consistent expectations, again, is probably one of the most important things. They need to know they're going home. They need to know that they're going to take care of themselves. They need to understand what their recovery process is going to be. Hospitals, I feel, are for sick people, not for total joint patients. 70% of the patient's recovery is up to them and their makeup, both genetic and otherwise. Only 30% is what we do. You need to stop the anticoagulants. You may consider a IVC filter or other anticoagulants to prevent blood clots. You need to assess them surgically, preoperatively, and we also do some functional assessments as well. Discussing pain management is also a big key here. They must understand they will have pain. They have to have a realistic expectation what that will be. In this article, in sports trauma, they talk about catastrophic thinking. And catastrophic thinking about pain as a predictor of the length of stay in the hospital and their outcome. So dealing and understanding the individual patient is very important. In the hospital, consistency, as I said, and I will continue to say, is very important. We also think in the OR, keeping it short and handling the soft tissues well and balancing the ligaments, as in my first talk, is very key to helping them through their recovery process. Consistency is key. Length of stay length of time in the recovery room, it should be short. They shouldn't be over sedated. Should elevate the head of bed, address their nausea and pain management. Now, this is probably one of the biggest keys, I think, is my theory of the 6-hour window. In the hospital, you should keep the operating time short. In the PACU or in the recovery room, you don't over sedate. Once they get to the hospital floor and into their room, get them up vertical, get them up with physical therapy, let them rest overnight, and then early the next day, disconnect them from everything that you can. Foley catheters, IV, PCA pumps, and then you change the dressing and let them go home. Post-op orders, being as consistent as you can yourself with your orders. The nurses get to know what to expect from you. Patients can do better. Early mobilization is also a good way to prevent blood clots. And if you have to intervene early with medical problems, do so. Pain, as I said before, stacked modalities. We use IV Dilaudid in a patient-controlled analgesia. Toradol, I'm a big believer in. Tramadol, Celebrex, Tylenol, hydrocodone, and oxycodone. But mostly, actually about 30% of my patients ultimately, because we balance them so well and we're careful with their soft tissues, basically use very little pain medication after surgery. We don't use blocks, either femoral or sciatic, as we feel it increases complication and it actually prevents them from getting up early. Preemptively control nausea, very important. We use around-the-clock Reglan, scopolamine sometimes, definitely Decadron, Zofran, and Pepcid. Get them back on their diets. Preventing blood clots, as one of the earlier studies talked about, is very, very important. We believe in early mobilizations, intermittent pneumatic compression devices, TED stockings. We use enoxaparin, as sounds like you do, in the hospital, but we risk stratifying and send people home on aspirin if they are low to moderate risk, enoxaparin if they're high risk. We believe in proactive nursing, encouraging family members to be involved. And on the discharge, we have home therapy or a home exercise program. Actually, I believe in more having them do it on their own, especially the first 4 weeks, not having a home therapist. We give them a support through office telephone calls, and we see them back in the office early. Initial post-op visits are 3 to 4 weeks, depending on whether they're a knee or a hip. And I feel that first 4 weeks, as I said before, is a recovery process. We remind them, as I remind you, that really the biology and the physiology of healing takes 3 to 4 months. So even though we are getting them up quicker, doing more, for them to heal and to feel more like themselves, they need to know it's going to take 3 to 4 months. Expectations, realistic expectations is key. After that, we get into more rehabilitation, increase their exercises, and then, up to a year to feel, especially with knee replacement, to feel more normal. We also like to keep progressing them along, give them something to do every time we see them. They need goals to get them well. Patient perceptions are very important. Hips tend to recover easily. They really don't need much follow-up. Knees, on the other hand, are not. 10% of all knees and knee patients are unsatisfied, and we try and make that better. 60% are doing better and are satisfied, and we see about 30% that just have an easy time. They're extremely pleased. And despite our short length of stay, very few of the patients we inquired had any problems with going home so soon. It's actually they tend to now want to go as quickly as they can. The recovery period, again, I think is very important. It's important to stay on target during this time. It's important to empower the patients to take ownership of their own recovery. It's really those that do manage themselves within the first 4 weeks that tend to do better. While we need to continue to evaluate surgeon and industry-directed factors such as new implants, MIS technique, navigation, clinical protocols, understanding and assessing these other patient factors, which we've ignored for a long time, really can influence our outcomes more than anything else these days. These are essential. Improved management of expectations, nutritional support, depression, anxiety, preoperative pain and function, and sleep apnea, and improved communication may be even more influential in determining implant performance and patients' ultimate outcomes. Therefore, we definitely need more research on these patient factors. Better initial screening so we can understand our patients individually and understand how to manage them better. We need to have better discussions like these to reach a level of understanding of how to influence the design and development of the next generation of implants and treatment pathways of this highly complex field. Thank you.